So I'm here at City Hall with Dr. Onkar Sahota, who's chair of the London Assembly's Health Committee. Welcome. So we've just had a meeting on how we can reduce the pressures on A&E in London, and it was proposed that primary care could be a solution to that. Could you tell us a bit about that?
Certainly, we heard from the chair of the Royal College of Young Practitioners that there is a lot of pressure in the A&E services and also pressure in primary care. And I know that extra funding is coming into the service, and some of the ideas which could happen is that GPs could make themselves more available. We could take on extra staff, so people who have chronic illnesses can be managed better in the community. We know that maybe the opening hours can be extended, but of course we also heard that whatever remedy is given will be a sticky plaster solution, but not a long-term solution to the problems facing healthcare in London and elsewhere in the country.
And I think already in London there are lots of CCGs that are putting in programmes where GPs open for longer or widen their access, but it requires a lot of resource. Do you think that's a sort of viable solution across London?
Well, I think, as I say, that whatever is being proposed during the winter months will be a sticky plaster solution. It's not a long-term thing. We need to look structurally of how the health system works for the interest of the patients. So we need to look at how primary care needs to be reformed, how hospital services need to be reformed, how social services need to be reformed, and how the community care needs to be reformed. But this winter months, certainly new investment is coming forward. Whether it'll be sufficient or not is a question which will be answered after the event. Okay? But everyone this morning was agreed there was a huge pressure. We will have problems in the winter management crisis, and that we need a structural change, and that what's happening this winter will only be a short-term remedy rather than long-term solution.
We've heard a lot about primary care kind of having a relationship with A&E attendances, especially from the health secretary. A lot of GPs sort of take issue with that because they think there are a lot of factors that affect A&E attendances beyond the control of primary care. Do you understand that they feel attacked by those sort of opinions?
Certainly, of course, it's a very complex reason why people attend A&E services, and also very complex why patients want immediate response to their illnesses. And if there was a simple answer, we should have already delivered it. But certainly to say, in simplistic terms, that it's because the GPs aren't opening their hours longer due to the contract is a wrong answer. I know, for example, although we didn't hear it this morning, that previously it's in the public domain that the NHS Confederation have come out and said it's nothing to do with the GP contract. That certainly the GPs don't think they're working as hard as they can do. And I did hear this morning evidence that the primary care gets the amount of funding to look after a patient for a whole year, equivalent to one single attendance in the accident emergency department, and therefore the system is acting in a way that patients can get good service sometimes in any department, but primary care isn't getting the investment that it requires to address this situation. So we heard this evidence this morning.
And this morning we also heard that you have been talking about kind of investment in primary care and moving resources into the community for quite some years. And your committee itself sort of questioned the experts on why that hadn't happened. Do you think that's a problem?
Of course, I asked this question quite categorically. We've been saying this for the last 60 years. Why hasn't it happened? I didn't get any answer, which was getting an underlying drivers of it. We certainly need a system which drives the flows of patients and money better. And I think what we need to talk about is integrating primary care, community care, and hospitals. Not only organisationally but also financially, so the systems act in a way that patients are given the best treatment in the best environment at lowest cost, and that it would be for many in primary care and community services. But there are structural problems. We didn't hear evidence about this morning, but I think that we need to look at why these cash flows are not flowing. Traditionally, the model has been, and I heard evidence this morning, that you make savings from the hospitals and that money will come into primary care. It's the egg and chicken situation. And I think what we need to do is make the investment in primary care so that we can pick up the needs of the patient in the community. And we need less in the hospitals. I think that's what we need to do, but something is preventing that happening. And we certainly need to look at the structurally what's happening, rather than just giving remedies or blaming anyone else for it. We need to work collaboratively across the systems.
Professor Claire Gerarda said today that she thought that GPs were being punished for the pay rise and the 2004 contract. Is that something you agree with?
Certainly, people have this perception, and I was on the radio this morning. This was a question that came up this morning, and Dr. Claire Gerarda was very clear that this is the impression that's been given. And I wish, right, if cutting GP salaries would be the solution to clearing the crisis of the NHS, right? It isn't as simple as that, right? Doctors' salaries need to be compared with salaries with other professional groups, and I certainly think that they work very hard. Doctors do work very hard, and the answer to any crisis isn't doctors' salaries, but the way that the NHS system works for the interests of patients.
How do you think it's problematic that this issue has become politicised?
I think it certainly doesn't. It doesn't help, but people will have perceptions, and people will want to pass the blame on to other areas. We certainly, as a committee, didn't look at this GP remuneration as an issue, but I can see why it is getting politicised, and Dr. Claire Gerarda was very clear that this wasn't the reason.
And just moving on to some sort of other areas now. So the Health Secretary has announced that he wants a GP to be a named clinician for every vulnerable patient. Do you support that idea?
I think that there should be a named person for the care of many of the patients. That is quite sensible. Whether it should be a GP or not, I think is also to be questioned, because we've been working against for whole years about primary care teams. The GP is one part of the primary care team responsible for the patient. It doesn't necessarily need to be a GP, but there probably needs to be some person who can access all the services the patient requires. So I don't think that we need to be particularly a GP, but having someone whom they can relate to would be a good idea. And continuity of care is one of the great benefits of primary care in this country. That we have a named list patient basis, right? Patients can identify the practices. I can understand it from a patient point of view, but it doesn't need to necessarily be GP. It could be a person in the primary care team.
And what's your take on GPs taking back control of out of hours? We've heard examples in London where GPs have tried to take it back and then due to competition law have been prevented from doing so. Is that worrying?
Well, I speak as a GP, but let's not forget that even if the GP contract is only from 8 a.m. to 6:30 p.m., it is still GPs who are working in the out of our services, whether it is through cooperatives, or whether it's through urgent care centres, or whether it is through other mechanisms. So doctors are working outside their contractual services for the NHS, and I think each area will have a solution for best solution for the area. And if doctors want to take on the service and can give a value for money for the patient, that's fine. That's all very good, and I encourage that. But I think we need to come to a solution which is in the best interest of patients, right, and get value for the money for the nation.
I understand that there have been lots of problems with late payments, especially for London GPs. We've heard sort of nationally that GPs have had to take out overdrafts because of late payments, and that in London GPs have been faced with threats from bailiffs. Is that a problem you're aware of, and is that something the Health Committee is looking at?
Well, the Health Committee certainly hasn't looked at this matter at all. But I am also a practicing clinician, and I speak here entirely from my perspective of being a GP myself, that there have been crises in getting payments on time. I read in the medical press that some doctors are facing a cash flow problem, and this has led to the part of the regularisation that's taken place and accountability. The CCGs have got less staff to cope with the functions than previously with the PCTs. The person responsible for payments is remote from your locality. New relationships have been built. There is a problem, and I know this is a problem from my own practices, and I think this has been replicated right across London and other parts of the country.
Going forward, what do you think would be the most helpful sort of strategic moves for London GPs?
I think for London GPs having clear direction of who is running London's healthcare would be important. I think one thing that's happened, and it's something we looked at this morning, is the fragmentation of healthcare in London. We've got 32 CCGs, we've got NHS public health, we've got local authorities getting involved with public health issues, we've got NHS bodies being health and wellbeing boards, and also we've seen the mayor trying to set up the health board and also the health commission. And the King's Fund report came out recently, and they said the system in London is very complex. We don't know who's making the decisions, who's responsible, and that clarity will be important. And I think what will also be important for the GPs to see investment take place in community services, in primary care, at a level which they can sustain to give a service. It's an absurdity that 93% of the NHS budget goes to the hospitals, whilst they only provide 10% of the healthcare in this country. And somehow, the funding isn't where the patients are seen. And I think we need to make sure that those flows are corrected. And I think we need to see more investment in primary care, in the estates structure, in the remuneration of providing the services, and correcting that balance. We also need to make sure that we heard evidence for this morning, that these intermediate beds, right, step down from the hospital, where GPs can admit patients for short, sharp interventions. Those sort of facilities will be very important. But also integrating community services, social services, GPs, and hospitals into one organisation. And my own personal view on this is that there should be financial integration and organisational integration.
And just one last question, if that's all right. The GPC recently said that they were confident that the Health Secretary understood that GPs are under a lot of pressure. Is that something you agree with?
Well, I look forward to the Secretary of State when he speaks at the Conservative Party conference next week, when he puts out the vision of the NHS to recognise the pressures on general practice. And if he recognises this pressure, I'm sure he'll say something about it next week.
Thank you very much.